This is where Dr. LeCocq worked at Swedish Hospital. It looks a little different than when he worked here. He worked a little bit further that direction. And he worked here for a long time, and what at the time was the biggest orthopedic group and remained so for years, the Seattle Orthopedic and Fracture Clinic. And there's, I see one member of the Seattle Orthopedic Fracture Clinic still here, Dr. Burns here, halfway to the back. The last department member we had that worked with Dr. LeCocq just was still working when we opened the Orthopedic Institute here in 2008. But he's since retired, Dr. Newton. And so the Orthopedic Institute that you're all in, this is one of the largest orthopedic facilities in the country, we're told, by its owners. And it's a very good institution. It's only orthopedic surgery. We have 9 operating rooms. We have 3 floors of patients. We do over 100 cases per week, orthopedic surgical cases. And so we rack up a mound of data that we so far have not mined very well, but we're going to in the future. So we're thrilled to have you come and talk to us today and tell us how to put our cups in better. So let's get on with that.
Thanks. Well, good morning, and it's my pleasure to be here, and I've had such a warm welcome with all of these lectures. This will be my last time speaking to the group, so thank you for your wonderful hospitality, and it's nice to see some old friends. See Dr. Goldberg here, a Bostonian who spends part of his time here on the West Coast. So I'm going to talk today about a subject that I think is a fascinating one, and that is positioning of your acetabular component in total hip arthroplasty. And you know, having been in practice now for 24 years and having done thousands of hips, I thought, well, I put my cups in perfectly every time. What are you talking about? Acetabular component, and how could I possibly not have 90% of my cups perfectly positioned if you do a radiographic analysis? Well, it turns out that's absolutely untrue. They're not that good. And this study was initiated by Henrik Malkow, and we were in the lab talking about how we position acetabular components, and the question was, well, how well are we doing? And we didn't really know how well we were doing until we did this study, and we presented this and won the Charnley Award back in 2010. So I'll show you just a little bit of the information about how well we position cups, but then I'd like to talk a little bit about how we might position cups better in the future and some of the work that we're doing. So we all know that malposition leads to poor clinical results. Dislocations, the primary dislocation rate is around 4%, and revision dislocation rate can be up to 14%. So dislocations are a major problem after total hip arthroplasty. Now that we think we have a pretty good handle on periprosthetic osteolysis, now we're focusing on infection and dislocation. So a malpositioned cup can be caused by a variety of factors: patient size, deformity, position of the patient on the table. We think the position is critically important, and lack of knowledge as to where the pelvis is on the table is one important issue. Visualization, guides, and others. So the first question was, well, what should we call our norm? What is it that should be the correct position? So the question was, well, what is the correct orientation? And if you go to the literature, there is no correct orientation. There are ranges that we think are appropriate, and those ranges are from some very old information using cemented total hip arthroplasty, and they range in version from 0 to 30 and abduction from 30 to 55 degrees, and you can see some of the numbers there. If you get your cup malpositioned, particularly if you have your cup in high abduction, if you're using on metal on cross-linked polyethylene, you're going to get fatigue fractures of the rim of the poly, and we know that. We've reported a couple of those case reports. If you're using metal on metal and you get a high abduction angle, you got real trouble, because there you get elevated wear, metal debris, high ion levels, and all kinds of problems. So it's even less forgiving. Polyethylene is relatively forgiving for malposition. Metal on metal is not forgiving at all. You either do it right or you've got a problem. And as you know, the same thing is true with ceramic on ceramic. If you malposition a ceramic socket, you're going to end up with stripe wear, failure, and squeaking. So there is a range, and the question is, what's the right range and what should we do? So we went back and looked in our registry and looked at over 2,000 patients. We identified the ones that we wanted because we had excellent x-rays on them. And we looked at a variety of different factors: age, gender, side, BMI, preoperative diagnosis. We looked at surgical volume, high and low volume surgeon, surgical approach, and femoral head size. And we looked at AP radiographs, and we used the Martel hip suite. I showed some of that data yesterday. We use it for wear analysis. And that suite also gives you as precise as it can be, because we have a jig that we use for positioning our pelvis, abduction and version angles. We use a shoot-through lateral, and again we use a computerized system to measure version, and that's shown both on the top for the AP as well as on the bottom for the shoot-through lateral. So we get a pretty good idea of abduction and version, and we agreed as a group that the acceptable range, the consensus for this study, the acceptable range would be abduction between 30 and 45 and version between 5 and 20. Now remember, version is additive, so if you have 10 degrees in your cup and you have 5 degrees in your stem, you have 15 degrees overall. But we didn't really look at the femoral component at all. So this is strictly looking at the acetabular component. So here's what we looked at. We looked at abduction and version, and here are the results. So if you look at cup abduction, only 49% of our cups, these are very experienced surgeons, all fellowship trained, every one of us thinking we're doing a great job, only 49% of them were in the ideal range. Version, we did a little better. 65% of them were in range in version, right? And here I'll show you these scatter plots. So the scatter plot shows the box. We want all of the dots in the box, obviously. The key here is to see how many dots are outside the box. So here are all the patients. This is 1,800 patients. Here are the primaries. Here's a high volume surgeon. There's a low volume surgeon. So you can see the number in the box represents the number that are correct. So a low volume surgeon only hit those values 26% of the time. Here's our best surgeon, and that is not me, 44.4% of the time. Here's our worst surgeon, 13% of the time. Here's the best approach, posterior lateral, 42. Here's our MIS2s. This is me. Dr. Andy Freiberg and I did these cases 17% of the time. Here are patients that are non-obese. There are patients that are considered obese by BMI, right? So what happens if you're out of range? Well, here's 3 cases I'll show you that are way out of range, just as an example of the extreme. But here's a patient with 53 and 35 of anaversion, 4 years post-op, squeaking, high cobalt chromium serum levels revised with severe lysis and alval. Here are all of our patients who underwent revisions at the MGH. So these are the patients in this series who were ultimately revised, and you can see that most of them live either outside the box or in the periphery, and the reasons for revision are shown there. So here's another example. This is a ceramic on ceramic kip, 59 degrees of abduction, 48 degrees of version, so well outside of the box. You see the red dot in the lower left as to where it is. And this patient ended up with eccentric wear. You can see it with stripe wear and a high degree of squeaking. So an example of a less forgiving situation. Here's a metal on polyethylene, and you can see it's yellow. So this was a recurrent dislocator with rim fractures, with a rim fracture of highly cross-linked poly. So you can overstress highly cross-linked poly and end up, obviously, with difficulties. And here's a metal on metal, and I think I showed you that one already. Good. All right, these are the revisions. Let's see if it does work. Okay. So if you looked at the univariate and multivariate analysis, the significant factors for cup malposition were, now this should be no surprise, Surgeon volume, if you do less than 20 cases a year, you have a higher rate of malposition. If you use an MIS or a mini anterior approach, those are the only two approaches that we had in this series, so we didn't have any others, but those were the approaches that had higher rates of malposition. If the patient was obese, obviously making it more difficult theoretically to see or to position the pelvis or to have the pelvis rock on you. And head size. So why would head size be a problem? Well, it turns out that when we went back to analyze this, and we looked at individual cases and spoke to the surgeons involved, what the surgeon did was said, well, the cup looks like it's malpositioned a bit, but I'll just put in a 36 millimeter head, and therefore it's not going to be a problem. So we got sort of lulled into thinking that a larger head was going to solve all of our problems, and clearly it doesn't. So here are the odds ratios, and these are the striking numbers. So if you're a low volume surgeon, your risk of malposition is twice that of a higher volume surgeon. If you use an anterolateral or a MIS approach, it's either 2 or 6 times increased malposition. If the BMI is greater than 30, of a 1.3 times increased risk for malposition. And so, these are the factors to think about. So when you're doing a heavier patient, maybe take a little bit more time. If you're doing a particular approach, particularly an MIS approach, you might want to think a little bit more about how you do it. So then we went to one of our community hospitals and we said, is this happening in our community hospital as it is happening in our university center at the MGH? And here's our community hospital, and there's the MGH at the bottom, and it's actually worse. So you can see how many more are outside the box than inside the box. So it's not just us, it seems to be everyone that isn't paying enough attention to the position. So what happens if you provide a surgeon a quarterly report for 1 year? Okay? So if you get your report card, Dr. Rubesh, here are your data, here are all of your joints, and here are your data compared to the rest of the group. Nothing else. Just give me a report, sent to me by email, I look at it. What happens within 6 months? Well, there I am, number 5. I statistically significantly improved my cup position dramatically, right? Dramatically, just by getting feedback. So feedback, as we know, this has been proven time and time again, but feedback is probably the most powerful thing that you can do to change surgical or medical activity. And what did I do differently? I can't tell you what I did differently. All I can tell you is maybe I paid a little more attention. Maybe I made a little bigger exposure. Perhaps I took more osteophytes down. I don't know what I did. But the fact that someone was watching made me do something differently. And that's true of 2 of the other surgeons as well. As a group, statistically significant improvement in our cup position just by looking at it. So remember, that's the Hawthorne effect for those of you who have any business background. That's if people will respect what management inspects. So if you got people watching over you, you're going to change your behavior. So what I'd like to talk about in the second part, and then I'll finish, are the methods currently for component placement in total hip arthroplasty. And I'm going to talk about a couple of them and show you some interesting work that we're doing at the end. So preoperative plan, my philosophy is that you plan your surgery before you go into the operating room and you execute your plan at the time in the operating room. So we use templates like everyone else. Having a good idea, or at least a thought, and thinking carefully about patient position. I position all of my patients. I don't know about you as hip surgeons if you do that or not, but I'm there for the positioning every time. I want to make sure I know where that patient is positioned on the table. There are a variety of external guides and devices that can be used. We use anatomic landmarks. You can use intraoperative x-ray. I do not use that. The only time I use an intraoperative x-ray would be a big reconstruction or acetabular reconstruction where the thing is so, the anatomy is so deformed that I want to know before I leave the operating room that I got it right. Patient-specific instruments, I have no experience with those, and then navigation and robotics, and I'll talk to you a little bit about that. So we use the M-Desk. It's It's a preoperative package that includes all of the different implants that you might want, and you can do a plan electronically and save it. It's no different than many of the commercial programs that are out there. Patient-specific morphology. Here, the patient matches the patient's individual acetabular component orientation. When people use this, and this is what I use, you can look at the sciatic notch. I don't look at the sciatic notch. You can look at the acetabular notch angle. I still can't even figure out what that is. You can look at acetabular bony landmarks, which is what I think I use. I try to go around and look at the plane of the acetabulum and try to make my cup parallel to that plane. And I always use the transverse acetabular ligament. Here are some of the data from the literature looking at different angles, and this is the acetabular angle on the top, which this is Don McCullum's work back from the early 90s. And then Bill Capello did some work again looking at the sciatic notch. Again, I don't understand how to do either one of these, but they're certainly in the literature. I think the anatomic landmarks are helpful. The problem is if you have osteophytes, if you have bony deformity, and if you have small incisions, your visualization is impaired. So it requires a fair amount of attention to detail to do this. This is some work by Nick Soterianos, which is in the Journal of Arthroplasty, and he used 3 points around the acetabulum. He used a point in front of the anterior wall, a point in the dome, and a point posterior to the posterior wall as well. The problem there is that these points are often difficult to get to, particularly if you're using a small incision, and if they're osteophytes, you can't really see them to create the plane. But this is the concept of creating the plane of the socket, the orifice of the socket, and placing your cup. This is what I use personally, and I use the transverse ligament, so I always find the transverse ligament. Most of the time I cut a portion of it out because it interferes with my reamer. I take the osteophytes down, and then I use the position of the cup and the orifice, the plane of the acetabulum as my guide, and the transverse ligament as my guide, and you can see that ideally it would be seated as you would see on the right. The middle would be maybe an oversized cup. The left would be an aneverted cup. So I use the transverse ligament and the osseous anatomy in that way, and here's an example in the operating room of how I try to orient a cup with the transverse ligament. Personalized instruments, I don't have any experience with these. They're particularly helpful around the knee. The data in the knee is suspect in the sense that it hasn't been shown to be an improvement using personalized instruments in the knee. There's only presentations. I don't know of any data in the literature on using personalized instruments for the hip. They're out there certainly, and the preliminary data suggests that they're no better than any other methodology except for computerized guidance. So I don't have any experience with personalized instruments. What we did do was a little study. Jim Slover, one of our fellows, and we presented this, we published this in the Journal of Arthroplasty, and we said, well, let's just take a theoretical personalized instrument system, and let's say that the imaging required is $4,500, which is what would be required to create the personalized instrument and do the either CT scan or MRI that you need to create the personalized instrument. So that's a relatively conservative estimate. So if the cost of the advanced imaging study and the development of the instruments is $4,500 or $4,600, then the revision rate has to be reduced 40%. 40% reduction from the current revision rate for total hip arthroplasty to be cost effective. Now you and I both know a personalized instrument is not going to decrease the revision rate 40%. It's lucky if it reduces the revision rate 0.5% or 1%. So to be truly cost effective, any of these new modalities has to have an enormous effect, particularly if they're this expensive, have to have an enormous effect on the revision rate to be cost effective. What about computers? Well, computers and computer-assisted surgery, it's coming. Certainly image-based and imageless navigation are here. We're particularly intrigued by the robot. We're doing some robotic studies. We have some early data. I won't talk about that today. But there, a robot includes a haptic system as well as a navigation system. The problems here are the steps, and I hate these steps. Registration, you got to put pins and reflectors in. If you're my size, you're always in the way of something. So I'm always blocking the reflectors, and they're always yelling at me, move here, move there. It just makes me crazy. Patient positioning obviously is critically important. You have to do registration, and I don't like it. I mean, there are some people who are patient enough and focused enough to do this. I'm not one of them. However, if you use the computer systems, the navigation systems, and the fact that they're invasive is one thing. Their general anesthesia is generally required because you can't get a spinal high enough to put these pins in the iliac crest. The surgery time is increased, but the data is very impressive. If you compare the reproducibility and the accuracy with the computer versus a non-computerized system, several people have shown this, Larry Dorr and others, that the computer-assisted cup position is more accurate and more reproducible than any of our traditional techniques. You can compare it to anything you want. If you're using image or imageless guidance, it's going to be better. And it's not better just a little bit. If you look at the freehand, the data here in the last 3 bullet points, you can see a significant improvement in the reproducibility. You narrow the window and you get that cup where it belongs. And this is Larry's work, where he did both a series of cadavers as well as a series of patients, and he found the same thing. Navigation allows more accurate acetabular component placement than the surgeon's intuition, no matter what you're using, what type of a guidance system that you're using, non-computerized. So computers, digitizing errors can exist. They're more time. Line of sight is there. They're more expensive, clearly. You can have fractures from the pins. Certainly you can get infections from the pins. And what I think we need is what's I'm going to call navigation light. We need something that works, that's reproducible, that's relatively inexpensive, and that tells the surgeon where the patient's pelvis is on the table. So I want to show you what we're doing and what we have developed. So we have a little device, and this little device on the left might be, certainly for the residents, might be something that you recognize. If you look at any of your computer games, you know, the little gyroscopes that you use, right? That's what that is. You know, you can buy one of these for about $20. The patents have run out on them. So basically, this device will give you an idea, a very accurate idea, of where it is in space. So let's take a patient. We put the device on the patient. We level the pelvis, and now we know where the pelvis is and where the device is with respect to the pelvis. Right? So now we put the patient on the table, and then in real time, this device tells you where the pelvis is with respect to where it had been when they were standing with blocks under them with the pelvis neutral. So it will tell you, is the pelvis rolled forward? Is the pelvis adducted? Abducted? Where is it? Real time. So it's recorded throughout surgery. This is what you can get on the recording, so you can basically know exactly what's happening, and you may not be able to look at that, but you can see the retractors are placed on the left. Then we begin the reaming. Then the patient is repositioned because we don't like the position with the cup impaction begins. You can see how things are changing. Look at the pelvis as you're impacting the cup, how it's shifting and changing. So we just did a preliminary study. We're actually very excited about this, and we're doing more and more of these. We're about to do a prospective randomized study comparing this to navigation. So here the surgeons were blinded to the position, but the surgeon's perceived pelvic position, we'll call that angle alpha, compared against what the unit measured we'll call beta. So beta is actually the true position of the pelvis. Alpha is what the surgeon thinks. So here's the surgeon's position, alpha. Here's the IMU position, which is beta. And you can see here the difference. So you just narrow the window once again. So there are the surgeons on the left without the IMU, and there's the IMU on the right. So with this inertial device, giving real-time information, telling you exactly where the pelvis is, you can reposition your acetabular orientation because you know that the pelvis has shifted, so now you know where to put the cup with respect to the pelvis because now you know where the pelvis is. So it's an exciting new technology. We call it navigation light. We're very excited about this. You can get leg lengths, believe it or not, from this. You can get cup anaversion as well as abduction. It's pretty interesting. Version 1 will be abduction only. Version 2 will be anaversion. Version 3 will be leg lengths. So with one little device, you can get it all real time, and so you'll be able to do this without sophisticated, and this thing's a throwaway, without sophisticated computers and navigations and pins and all of those things in the operating room. So a system in which the pelvis could be monitored and adjusted intraoperatively based on accurate position data would allow the surgeons to place the pelvis in the optimal position prior to cup impaction and increase our overall cup placement accuracy. We think we have some data to suggest that that might be the case, and that we think this may be an accurate and a non-invasive way of doing it. So more to come on that. So the conclusions of this work, it's interesting work. It was surprising to us and continues to be surprising to me how inaccurate we are in doing this, is that as a surgeon you need to focus on your surgical technique, you need to know the type of alignment guide that you're doing, and you need to have preoperative planning algorithms. That's critically important. Be cautious certainly with hard-on-hard bearings and malposition, we know that. Avoid many incisions until you have relatively high level of experience, so you know the system that you're using, and as you take more and more of your visual clues away with smaller incisions, make certain that you have it right first before you start decreasing the size of your incisions. Navigation and animated preoperative planning improves our accuracy and reduces our outliers. That's the one beauty of navigation. It really works and it will help you. You just have to put up with the pain and suffering with navigation. We need simple navigation solutions. What I showed you is one. We've patented and now licensed that system, and it will be available in the near future. I think robot technology is fascinating. I'm probably a little too old to greatly to appreciate the true impact that the robot may have, but I'm very excited about what robots can do for us, and we're about ready to begin as I said, a prospective study on robotic technology as well. I'm very excited about intraoperative navigation devices and ways to make this operation actually more reproducible and more accurate, particularly. And if there's one take-home message here, review your own data. You suggested that a registry is an important thing. I can't emphasize that enough. Take a moment, get somebody to pull your cases, pull them up and look at them. You'll be shocked at the findings, as was I. Thanks for your attention. Yes, hi.
Have you used the IMU device against an intraoperative X-ray to see if you're more accurate?
No.
Is that something that seems like an intraoperative X-ray? We use it at the VA often.
Mm-hmm.
It helps us visualize it. But I wonder if we're as accurate in estimating that when we can't break, scrub, and measure.
Yeah.
You might be with the device.
The intraoperative X-ray really tells you if you're way out of bounds. An intraoperative X-ray will give you a sense of abduction. It doesn't give you version. So I'm not intrigued with them. I use it as sort of a gross test, and I only use them when I have a mal-union of an acetabulum, or non-union of an acetabulum. I have to move things around. The anatomy is so distorted. And so I don't know, are you taking a plain film or are you using a C-arm? Plain film. So I think the plain film is superior to a C-arm. C-arm lies. C-arm, you get a bad image, you twist it, it's got different planes, it's crazy to try to understand a C-arm. So I think it's better than nothing. It will certainly take away your outliers. So in that one case where you have the cup too vertical, it'll tell you and you'll go back and move it. So I think it's better than, it's okay to have it, it's better than not having it, but it's only an outlier catch. Catches the ones that are really off. And it doesn't give you version. For
the IMU device,
Mm-hmm.
it's attached to the skin, so how do you account for the shearing of the skin relative to the
Great question. It's one of the things that we worry about. Again, that's just a small study section, group of patients that I showed you. If you put it right at sort of the lumbosacral junction area, most patients that's not where adipose tissue seems to collect. It likes other areas more than that. However, without question, the skin is mobile and the skin will move. And we'll be able to answer that question better in the future because we're going to do a head-to-head comparison. It's relatively stable. Only in the small number of patients that we've done, when we do position them, we don't see any translocation of the device because the device will tell us if it's moved. I mean, it knows where it is in space, right? So it tells you exactly where it is. So we can detect a change in its position precisely. But that's a great question and something we have to deal with. And you know, if you look at gait analyses, there was a problem with lower extremity when you put reflectors on the skin. You didn't get the accuracy until you put pins in the bone. So that's a liability. We'll have to work it out and see if it works. So far, it's been good. The cadaver work has been fabulous.
How is it actually attached to the skin? Is it
Tape.
tape?
It'll be a non-irritating glue of some kind that's used in the operating room. We don't know yet what it's going to be, but right now we tape it, duct tape.
How much attention you pay to combine femoral and aspect of aversion? You happen to have a femur that brings its
Yeah. Well, you know, that's the point. The point is if at the end of the day, the experience, either you have to have full navigation. You can use this for the femur yet. We're still working on some of the details of how to use it for the femur. To do it on the femur requires that the device be sterile and used, you know, during the procedure. So we're not sure that we need that yet, but that's a possibility. You can actually make these things disposable and sterilizable, and you just turn them on, and they're on for a couple minutes, and you throw them away at the end. So the IMU can be used during the case, but we're not sure how necessary it will be. The anaversion is a reflection of both the cup and the femur, so you have to take the femur into account. That's what you get with navigation. With navigation, you get the socket as well as the femur, so I think it's one step better. The question is, do we need that additional information to do a hip well? So I guess the purist would say yes, you have to have it all. And my hope is that an experienced surgeon doesn't need the data from the femur as much as he or she needs the data from the socket. Sort of non-answer, but that's as best as I can describe it. So, can we develop the IMU to be used for the femur? Without question, we can. So you just have two of them. And the beauty of having two of them is, if you think about it, the two of them can then talk to one another. So how are we going to get leg lengths? We're going to have one on the positioner. So now the one on the positioner knows where it is with respect to the one on the back. Therefore, you know where the leg lengths are. So that's sort of down the road. So we'll get to the femur, but we're not sure it's absolutely necessary. We're going to offer it both ways. Yeah.
Just sort of building on that, you know, we talked about the ideal abduction angle of a cup.
Mm-hmm.
With our uncentered stent now, we're generally following inversion across the femur, and you know that can vary significantly with a dysplastic or a mildly dysplastic hip versus a retrograde femur, males particularly. I just wonder if our definition of the ideal abduction angle of a cup needs to change, like you kind of alluded to, where inversion is a combination of both sides. I just wonder how has that been looked at? Should we talk about that more?
I think the answer is yes. We should be more aware of it. The point is, you know, if you really step back from this and you say, well, what's the point here? Well, the point here is out of those 2,000 hips, you know, that we looked at, you know, let's say half of them were out of range, but I didn't show you 50 or 5% of them dislocating. There were very few of them that were dislocating. Why? Because, you know, take the cases I did. In the cases where my cup maybe wasn't anaverted enough, I just kicked the femur forward just a little bit. In cases where the cup was abducted too much, you know, I would hopefully have gone back and brought it into a better position. But you know, we can change the femoral component to adjust for what we do with the socket. And when we do after you reduce the hip and you go through a range of motion and you look for instability, I mean, you're compelled to change it if you need to. So I guess the answer, the answer would be we do, and that gets back to, I think, Alan's comment, we do need to know both, ultimately, and they are both interrelated. And what we've done is sort of dissected them out as an independent variable, and I don't think it's as powerful having it independent unless you, it's not as important independently looking at the socket as well as it would be if you had both sets of data. I think that's more compelling. So I agree with you. I don't know how to get there, though. That's the problem. Great.
Do you share this information with your patient? And do you use it ever to modify a patient's activity?
Do we share the information with the patient? I tell them if I like it or not. I mean, I tell them the X-rays look great. If the cup is malpositioned, do I tell the patient? Say the cup's 60 degrees, would I tell the patient? I probably would say something like, the hip looks good, but I don't like the position of the socket. It appears a little more vertical than I would have liked, and I'd like to have it down. So I would inform the patient if I had a gross malposition of the component. If they weren't dislocating, I would say that probably not going to end up with a problem. But if they were dislocating, I'd tell them that the cup is too vertical and we probably have to change it and put it in a different position. As far as the routine patient who is doing well, do I tell them that their cup's 49 degrees versus 45? No, I just tell them it's in range. Yeah. Do I modify activity? No, not at all. And probably not warranted. Yeah. Polyethylene's pretty darn forgiving. Hard bearings aren't. So with polyethylene, you can, if you look at all of our wear data, so if you look back at the wear data with polyethylene, that would be, the assumption there would be that those cups have a large range of malposition. And, the data still is pretty strong as to how well crosslink poly does even with the malposition. In fact, how well regular conventional poly does even with the malposition. Great, thank you.